Okay, so this was also a pinch hit a little bit because Dr. Pitts was unavailable today. But Dr. Edwards wanted us to go through just kind of an update on some of the perioperative nutrition things that we're working on and just in general what's going on in the community. So we have surgery with an inherent nutritional risk. And part of that is going to be a chronic situation, and part of that is going to be an acute situation just because of that process of surgery happening. With chronic situations, we can define this as malnutrition, which can encompass a variety of things. Mostly we think about malnutrition being wasting, right? You think of someone who's lost lots of muscle mass, and that's like the ESPN guidelines looking at someone with a BMI under 18.5 and defining that as this is malnutrition. But we have other aspects as well. Stunting, which you commonly think about, little kids, but that then becomes a chronic condition. Once those kids are older, that stunting remains. Micronutrient deficiencies, that could be because of overall nutritional risk factors, things that are going on, or it could be very specific. For example, we have a neighbor who is dealing with some micronutrient deficiencies because he's autistic and will eat 3 foods. And they are white bread and mac and cheese. And I don't remember the other one, but yeah, it's like, it's nothing. So he's developed over his 25, 26 years of life some micronutrient deficiencies because he's spent those years eating those 3 foods, right? And then the one that is the most common, which is overweight and obesity, which we don't think about as being malnutrition, but it is. And oftentimes it's because people don't have access to healthy foods, and so the foods they do have access to are very calorically dense and very nutrient poor. So we have this surgery nutrition continuum that ranges from severe malnutrition, be it on the severe obesity side or the chronic wasting kind of side. And then we have at the other end that people are doing really great, good nutritional status, but why would we send someone into a surgery? Like, why would we run a marathon without eating a meal first, right? So that's kind of the continuum of individuals that we're all in that place and we're all working with. So as far as my job, it's to look past that basic screening of, okay, what's their BMI, and take a big picture of what's going on in their life. And that includes things like the obvious dietary assessment, looking at what's someone eating, but also what's their appetite like. What are they dealing with that's making it hard for them to get quality food or to feel up to preparing those meals? Because there's people who are in pain, who are in a situation where, like, you know what, I just don't care. I don't feel good enough. I know there's stuff in the fridge, but I'm not going to eat it because then I have to get up and walk to the fridge, and that hurts. And then I have to go into the kitchen and prepare it, and that really hurts. So just forget it. I'll grab a can of soda and call it good. So you've got those conditions as well. Anthropometry, which is more than just weight. It's an image of a DEXA scan, which is probably one of my favorite ways of looking at body composition, just because it's accessible. You know, a combination of CT and MRI is better, but that's impractical. So, you know, the tools that we have are really quite good. A nutrition-focused physical exam. This is where we're actually palpating someone's muscle and fat stores, palpating for edema, looking at, for example, their clavicle. How far is that indentation? And then looking at places like the mouth and the eyes and the nails in particular for some of those micronutrient deficiencies that can show up. Biochemical analysis, prealbumin's my favorite. Functional assessment, an easy one is hand grip strength because it's simple, and there are some pretty strong relationships between hand grip strength and malnutrition and morbidity and mortality. So I sent this article out. I don't know if anyone had a chance to look at it, but this is an example of taking a basic malnutrition screening and applying it to a group of people who are going to have a surgery. And this in particular is a group of patients who are dealing with an adult spinal deformity. And then they did a screening, categorized them as either malnourished or not. There was a control group of not malnourished at that point, a malnourished control group, and then a group that they did some nutrition intervention, including education, follow-up, and some supplements. They also did some autotransfusion and non-autotransfusion subgroups within that, which was an interesting thought that actually didn't show any significant difference between those groups, but that nutritional intervention did have a very positive impact on decreasing those complications in the malnourished patients. They also noted that over time, because this was a longer-term process of preparing for these surgeries, that there was a natural increase in malnutrition in these individuals that kind of demonstrated that just this situation itself of having this adult spinal deformity led to malnutrition, but those interventions helped decrease that rate of decline. Anybody have any thoughts on that?
I think it's not just nutrition, right? Your nutrition will play into effect depending on your functional status too. Like you can take all the calcium you want, but if you're not loading your bones, it's not going to get to your bones. And you can, drink muscle milk all day, but if you're not engaging your muscle, you're just making expensive pee at that point. So if
what we have to move too. Yes.
So I can see that if you are deconditioned because you're in pain or you're just not moving, then your nutrition is not going to translate into meaningful nutrition.
Definitely, thank you. Yeah, and it's amazing how much all of those psychosocial, physiological, different factors come into play to make those decisions for what am I going to eat or am I going to eat happen or not happen. Thank you. Okay, so we're going to switch slightly, but still in the same line with some of the ERES protocols. And essentially we have a situation with surgery that we're preparing for the surgery by fasting, which is backwards but necessary so we don't have people aspirating. And then you've got that in combination with the fact that our bodies are really awesome at wanting to repair those tissues after that surgical procedure. It's like, oh, something happened, I'm gonna fix it. And that's good, except that it draws from those muscle stores to be able to do that. And not only are we pulling proteins from the muscles to create those cells that we need for repair, but our body does this quirky little, well, I'm gonna pull that protein for energy too, because I don't have enough energy and the muscles are the easiest, fastest way, so that's where I'm gonna take my energy to create new glucose, that gluconeogenesis process. So we're losing because our body needs to make things better, which is so backwards, but is the way things work. And it's a good thing that our bodies can do that, but we want to support that and avoid some of this nutrient deprivation as much as possible. And when you think about it, when you've got someone who is in a state of malnutrition, that makes it even worse to be able to say, okay, we're going to go into some deprivation here, and you're starting out way down here, so we're going to crash you down even farther. So we want to help and cause some support for everyone. Current protocols are people can have a solid meal up to 6 hours before surgery, clear liquids up to 2 hours before, ideally with a 12.5% maltodextrin solution at that 2-hour time point, and then IV fluids to maintain fluid balance during surgery and early post-op feeding. So tell me how this is working in the facilities that you're in and with the people you're interacting with?
I think it depends on the facility. I don't have the second point that you have implemented for my patients, but I can totally see being in a facility, wanting to do a case, and everybody freaking out if the patient has even said, yeah, I drank like just a little bit of like, a sip of water or something, and people freak out. It's like, it's okay, you can have a sip of water even if it is an hour before. And one of the at-risk patients that we struggle with is diabetic patients, because they have gastroparesis. For them, it's not solid meal up to 6 hours before surgery, but it's longer. And those patients already, diabetes is a malnutrition,
Yes.
disease, and those patients are NPO for longer, and they tend to have so many more changes in their blood sugar profile.
Yeah.
I think as a former nurse on the floor, pre-surgical, the mindset of people it's a little old-fashioned. When Dr. Edwards presented this at Utah Valley Hospital, all the nurses and all the doctors were like, "What? You're gonna do what prior to surgery?" And it's a huge, and it still is a mindset. It still is, no, that's not what we do. And having to get the anesthesiologists on board and other doctors on board and nurse managers and nurses, and because the old thought is, we fast as soon as they get done the night before, even if their surgery's at 4 o'clock in the afternoon, we're making them fast. And I'll be honest, on the compliance part for patients and the ability to take care of patients and keep them happy, this works much better.
Yeah.
And seeing them on the back end, post-surgical in the home, if we have provided them the opportunity to have some of this adequate nutrition pre and post, they heal better. So it's all about a mindset. It's all about getting away from old thoughts, old traditions, and actually accepting the new evidence and saying, okay, we can see why this would make a difference.
Yeah.
I know that in our family there have been a few procedures lately, and it almost feels like it's a competition to see how long you can go before surgery without having eaten, and it's like you get a bigger smile from the staff if it's a longer period of time, and if it's a short period you get kind of that, okay, I guess you're probably all right. But so it's that mindset that needs to adjust a little bit. We're working on adjusting. So
When is the drink thing?
we're getting there. 1 second. So this is what we're working on, and we're doing a study to kind of provide some of this information. So we've got a supplement. It's got 45 grams of carbohydrate, 12 grams of amino acids, some vitamins and minerals that, based on a very large literature search, help with surgery recovery, and that combination of the way the nutrients are put together facilitates gastric emptying, which is a positive. And then we're also doing a component of nutrition education and have a control group, and then both with and without the supplement. So the first question is, are those amino acids okay? Is my patient going to just never empty because of those amino acids? So this is a quick biochemistry reminder. So an amino acid requires no digestion. It's just all by itself, so it's going to go through the stomach at a relatively fast rate. We have proteins that go a little bit more slowly, but most proteins, that emptying time is not as long as we think. The protein that has gotten the most press, because in large quantities it can cause slowing of gastric emptying, is casein. And these are my drawings, but they're kind of what the molecules sort of look like. But you can see this is a much denser, heavier, bigger kind of a molecule than most of the proteins are. And so that, in combination with just the way that it's formed, does slow things down. But there have been some studies that, they've given people tea with a little bit of milk in that tea, and it hasn't, hasn't slowed down that emptying time. So We're taking gastric ultrasounds. This is an image of an empty. The supine ones are so much easier to see. See that cute little donut? That's your stomach. The liver is right there. Makes a nice little landmark because it points to the stomach. Isn't that cool? Same thing on the, if you're going to the right decubitus, it's just a little bit harder to see that image. But this is actually the one that we want to look at. And then we're giving a dose of the supplement and then following up afterwards. So it's a little tricky to see, but at that 30-minute time point, you see the cute little sparkly white dots in there that are the particles. The volume's a little bigger. The volume's easier to see in the right decubitus. And then you follow the emptying. And for this individual, at 75 minutes, they were empty. 30 minutes, if you look at that supine, it actually looks pretty close to empty, which is why we use that decubitus measure, because that gets lower down there in the antrum to be able to say, okay, this is the end of where things are emptying. So for our first 45 patients, this is what the data looks like. We had a mean emptying time of 73 minutes, standard deviation 17.7. But if you look at it, almost half were emptied by 60 minutes, 3/4 by 75 minutes. We had these 3 outliers that were at 120 and 135 minutes. I am not sure why. They were all on the same day. And they were all young, and I don't know what was going on that day. So I'm actually rerunning the person who was 135 minutes just to verify that's really where she is. There's another way to look at this besides just visually looking at the emptying, which our sonographer was the one that did that. I stayed out of it so that it's somebody else, not me. But we can take this volume using the cross-sectional area. There's a calculation that was created based on taking those measurements and then aspirating stomach contents to be able to get what the actual volume was. Age is a factor in that. And if we look at those numbers, there's a normal gastric volume that they have determined to be safe. So if someone just has normal gastric secretions, if it's up to 1.5 milliliters per kilogram or less, then that's considered to be safe for surgery and at a very low aspiration risk. So by 60 minutes, all but 3 of our participants had reached that phase of being below that 1.5 per kilo. And by 75, all but 1. And that one outlier is the person that we're going to redo anyway and just see where things are. And if, there's probably a chunk of the population that they're just really slow. If you look at this data, this was looking at what their initial volume was and comparing that over time. And there were a large chunk of them that their gastric volume was lower by those time periods than they started with when they were still fasting. So having that fluid going through their stomach actually decreased that volume, because there have been some other studies that have looked at this as well, that having those liquids in actually is better for gastric emptying than just fasting. Sex doesn't seem to make an impact on emptying time, although our 3 outliers were female. BMI doesn't seem to have an impact. We had a range of 18.8 to 46.2 amongst the group, and both of those endpoints were empty at 60 minutes. So that's a good thing to be aware of. Our farther out ones were actually pretty normal BMI. Age range doesn't seem to have an impact. Had an age range of 20 to 80, and so that's good to know as well. Tolerance was good. There are a few people who had some symptoms when I queried them afterwards. It was more that I always get sick when I fast, and I'm feeling the same way I always do when I haven't eaten. So it wasn't that the supplement made things worse. It was, unfortunately, it didn't take away all of that nausea that they typically have. The aftertaste seemed to be more of a factor in people who didn't consume nutritional supplements regularly. And they were also the ones that rated the taste and experience a little bit lower. The people who were consuming supplements more often were like, oh wow, this is great. And the people who didn't were like, yeah, I don't want to drink that because it's not my favorite. But there wasn't any really super negative. And everyone said they would definitely or very likely be willing to take that if it were given to them before surgery, which is another positive. We have done one individual who was on a GLP-1 agonist, and she's actually been on them for about a year. Her BMI had been down from, I believe it was 46, and it's now 39 over the course of that year. And 56-year-old. She was actually empty visually on the scan after just an overnight fast. So I just had her eat as normal the night before, come in fasting that morning, visually empty, measured empty at a 0.44 milliliters per kilogram. She took the supplement and then was visually empty again by 2 hours, so it was a little bit longer time period as anticipated. But by that point, she was down to a negative 0.05 mils per kilogram, which is essentially empty. You know, there's a little bit of noise there. But she measured empty by 75 minutes and was below baseline by 105, indicating that this individual didn't actually have that much slower of a gastric emptying time process than someone who was not on, she was on a semaglutide injection. But we need more people to look at that. She may be an outlier. This may be pretty normal. So anybody who knows anyone, we need your help recruiting to try and get some more data. I had a patient the other day who was really frustrated. She's having surgery actually today, and she's hypoglycemic, really worried about this fasting, has to fast for 2 days because she's been on, I don't know which of the GLP-1 agonists, and was like super excited that we were collecting data, but having surgery today, so we'll give her a break for a couple of weeks. But people are interested and would like to know what this time is, because the current policies are just based on a guess because there isn't any data. Thoughts?
I'm sorry, I'm ignorant to what a GLP.
Oh, so it's like the Ozempic and those other Wegovy, those medications for weight loss. Yeah.
That's what you were talking about.
Yeah. But the mechanism of action is that it slows that gastric emptying, so people feel full longer and are going to not want to snack and eat as much. So for those individuals that's the reason for their weight challenges, it can be helpful.
It slows it down so much that anesthesiologists will want you to be off of the Ozempic for at least a week, and they have longer, fasting periods because it really slows it down so much. And this patient, did she stop her Ozempic? No?
She's
Okay.
still on it.
She was one that was in the study.
Mm-hmm.
Was she that outlier, or was?
No.
Okay. What's her name?
I was expecting her to actually be longer. I was actually not expecting her to empty in that 2 hours, but I also didn't want to make people come and stay for forever. So my goal was to find out, okay, what's the measurement before, and what does it look like compared to those empty guidelines? And then after that 2 hours, how close are they? So I really wasn't expecting her to empty, but she did. The person that was the outlier, I'm not sure what was causing her slowness, but that's why I want to run her again and just see if there was something that, just to make sure that we're consistent in that, because she was such an outlier from the other normal population. We're also running someone in a couple of weeks who has gastroparesis, quite severe gastroparesis, and we want to see what's going on with that. Part of the hope with the formulation was because of the combination of nutrients that do enhance emptying, that it would be helpful for these people who have some of these challenges with emptying to be able to push that through a little bit faster and get the nutrition in while still being safe and getting those clearances that we need. So And we're in manufacturing. Should be like 3 weeks. But I've heard that before. So I'm hoping because, yeah, we'd like to get this into.
So are
be
you
able to help our
checking
patients.
pre-albumin levels as part of your lab work prior to surgery right now?
No, but I wish we were. That's my favorite indice for the biochemical. Just because it's easy to get, but it's like a couple of days. So you're getting a closer short-term picture than albumin is just, it's too far out and too variable and doesn't really show as effectively what's going on as far as nutritional status.
So I have a question. I'm just curious. It is now so quick and easy to measure this with the ultrasound. Why isn't this just part of the pre-surgical protocol? If we're so worried about aspiration, why don't we just measure before we put them under surgery?
And that's a good question. I don't know the answer because, yeah. Partly it could be just one more step and it's easier to just make everybody fast.
Yeah, that seems like the wrong approach.
Yeah, but it is pretty easy. I mean, if I can run them, so everybody can.
2 minutes. I mean,
I think ultrasound is a difficult skill to learn. It's not an easy skill, and to train it across the board in not only hospital systems but in surgery centers and outpatient
yeah, but I think
departments.
about what's the cost of just one aspiration? I mean,
Huge, which is why everybody has to
so-
fast.
I mean,
Yeah.
I'm just saying, one ultrasound tech could handle the entire surgical suite, right? I mean,
Yeah.
it literally is 2 minutes, and they'd be busy all day long, but it would be simple.
I think again, it's the mindset.
It is.
Right? What has tradition been in the last however long?
Since the
we've been on
1940s.
Right, and
Yeah.
so agreed that it's there, the evidence is there. It's who are you gonna get to change that mindset, you know? And
Yeah.
so I think it has to start not only with the doctors, but it has to start with hospital administration, it has to start with the anesthesiologist. Somebody's gotta come down and say, no, this is what we're doing. And we've seen changes like that. I've been on a surgical floor for 7 years. Like, we've seen little changes come through, but it takes a long time to get one little change, to change that mindset of people.
If there was an ideal way to ideal diet for a patient as they're preparing for surgery, are these what is the minimal amount of timeline that you would say, okay, I want to make sure that by this time I have a point of contact with a provider who's making sure that your dietary requirements are good, whether it's a specific micronutrient supplement or what's your protein intake like on a day-to-day basis? What is the timeline that we're looking at?
So if someone is malnourished, it obviously needs to be a little bit longer. And so that's hopefully someone has at least screened and has some sort of an indicator that, hey, maybe this person needs a more thorough assessment. For everyone, a couple of weeks out, I want them on 25 to 35 grams of protein per meal, and I want them on a multivitamin, multimineral supplement, and I want them eating lots of fruits, vegetables, whole grains, cutting back on their sugar, cutting back on the like the fried fatty kinds of foods, so that we're maximizing their nutrition for at least that couple of weeks right before. If they need to lose weight, even just losing a pound over the course of that week or two before surgery does have enough of an impact that it makes a difference as far as safety. So ideally, if they need to lose some weight, getting that a little bit off then. Although I have a lot of people who I see who need to lose a lot of weight, who are so malnourished and eating so poorly that I don't talk to them about weight. I say, okay, if some weight comes off, that's great. But right now you're eating like 800 calories a day. You feel horrible. You are not losing any weight. So I want you to start eating food. And they'll come back in a few weeks and like, oh man, I feel so much better, because they're eating healthy food and not just trying to cut back on calories to lose weight. And they're not gaining weight when they're adding those extra nutrients in. So at least we have that positive, but they're in a much better place for surgery, even though they still have that high BMI.
That is so nice. You probably are one of the very rare providers who tells them to eat, because it is really sad. Like, you know, when you see patients who are obese and who are like, but I don't eat anything. I'm like, I don't think that's a good thing for you.
They don't. They're so afraid of gaining weight, and they're so afraid of, if I don't lose weight, they won't do the surgery. What am I going to do? I can't lose weight. I've tried. I'm hardly eating anything. And like, great. Just, we're going to stop, and we're going to forget the weight. And I don't even want to know what your weight is, except that I have to write it down. But let's get some good nutrition in you and get you feeling better, because right now you feel horrible, and it's not going to go well. They're not moving, and they're hurting, and they feel lousy, and they have no energy. And if we can get some nutrition in them, they can feel a little bit better, so they can start moving, and then that helps them, you know, with that muscle mass too.
I think with some of these chronic, where they've got these chronic issues, I'm just thinking of a woman I've been working with that had a knee arthroplasty, and I can't tell you how many visits she missed post-operatively with the rehab. This really, really crucial phase, because she has these chronic issues with her gallbladder and other issues, you know, gastric issues, and she's just GI issues. So she's missing half of her visits, you know, and you start to look at like outcomes of that. It's like, well, what's going on here? You're not doing your therapy. Well, she can't get out of the house to even come in and do that.
Yeah.
So it definitely has some long-term consequences.
Yeah. And gallbladder surgery is not benign. I mean, we used to think, oh yeah, you don't need that, but it can cause a lot of problems. So, yeah.
And we minimize laparoscopic surgery too, but really they're inflating the belly and they're moving all the guts around, and
Yeah.
I'm sure
It's not
that's
nothing.
pretty
Yeah.
traumatic.
Yeah, definitely. Well, thank you. Appreciate you all coming and braving the roads in the storm, pseudo storm. Right.